Hello, and welcome to the University of Alberta Child and Adolescent Psychiatry Grand Rounds. I'm Dr. Alice Liang, and I will be moderating today's presentation. We are very grateful to be partnered with the Faculty of Medicine and Dentistry Office of Lifelong Learning, or L3, who provide much of the technical and logistical supports for these rounds. So our presentation today is Genomic Psychiatry, implementing precision medicine for autism and developmental conditions. We acknowledge that we are on traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marched these lands for centuries. So a bit of webinar housekeeping. Please use the chat feature if you have questions about the technical running of these rounds. And if you have a question for the speaker, please use the Q&A feature. And our speaker today has kindly agreed to stay until 12:15 p.m. For Q&A if there are questions remaining. And also you can upvote the questions you would like answered. And while we cannot guarantee that the speaker will be able to respond to all of your questions, the question and answers will continue to 12:15 p.m. So definitely do put your questions in the Q&A. So now I'd like to introduce our speaker, Dr. Daniel Moreno De Luca, who is our inaugural CASA Research Chair, completed his medical degree in 2005 at the Universidad Industrial de Santander in Bucaramanga, Colombia, after which he completed a master's in neuroscience at the Université Pierre et Marie Curie, Sorbonne Université in Paris, France, then did a postdoctoral fellowship in neurogenetics at Emory University in Atlanta, Georgia, followed by his clinical psychiatry residency at Yale University, his fellowship in bioethics at Harvard Medical School, and his child and adolescent psychiatry fellowship training at Brown University, where he has been an assistant professor of psychiatry and human behavior since 2018. Throughout the same period, he was also the clinical director of the Bradley Hospital's Genomic Psychiatry Consultation Service and attending child and adolescent and adult psychiatrist at the Verrecchia Clinic for children with autism and developmental disabilities. In his new role as the CASA Research Chair at the University of Alberta, Alberta Health Services and CASA Mental Health, Dr. Moreno De Luca focuses on the impact of genetic variation on brain disorders and how to use these discoveries to enhance patient care. Along with his precision medicine and autism, or PRISMA team, and in close collaboration with community services, he aims to contribute to genomically informed interventions and precision medicine solutions based on his research into the genetic underpinnings of autism and other neuropsychiatric conditions. So we are delighted to have you, Dr. Moreno De Luca, here with us in Edmonton and presenting today.
Thank you so much, Dr. Liam, for the kind introduction, and it's a pleasure to be here. And I'm really looking forward to sharing some of the work that our team has been focusing on and what we hope to accomplish in this next iteration of in this new chapter of our work here. So let me share my screen and then we can get started. So in addition to liking the colorful intro, I promise that the characters on that intro will make sense in a little bit. I would like to echo Dr. Liam's territorial acknowledgement. I am very grateful for the privilege of being here and working here. So now some housekeeping slides in regards to my disclosures. I have research support from the CASA Research Chair and none of the other areas in this slide to disclose I'm an employee of the University of Alberta and Alberta Health Services. This presentation received financial support as part of my CASA Research Chair Fund, and I have received previous funding from the National Institute of Mental Health, Brown University, Yale University, Bradley Hospital, Hasbro Children's Hospital, and the American Psychiatric Association. This presentation has also received in-kind support from the following academic institutions that we named already. I have not received any payment or funding from pharmaceutical or genetic testing companies, and we will be talking about the use of off-label medications. And bias will be mitigated by acknowledging all of these disclosures. So let me start with why we chose the name PRISMA. So it's a far stretch of an acronym for Precision Medicine in Autism, and we really like the analogy with the work that we do and a prism. So we get on one side an undifferentiated stream of light, and then through knowledge and the tools that we have, and in close collaboration with key partners, we're able to break that light into the wonderful colors of the spectrum. So let me tell you a little bit more about how we do that. Prisma is also the Spanish word for prism. Spanish is my native language, so it's a little bit of a nod to our focus on diverse populations. And I wanted to start with some frequently asked questions. So we heard the name of the title, Genomic Psychiatry and Genetics and Autism. So I'm pretty sure that some of these questions may be going through your minds, and that's good. We want to address those. We can start by talking about how all of these psychiatric diagnoses are very different. Then we want to learn a little bit more of why genetics are relevant. And my argument here is that genes haven't really read the DSM, but we'll delve more deeply into these. Then we'll focus on these rare genetic conditions and why are we spending so much time if these are rare. Then we'll focus on some perceptions around genetics, and maybe you don't want to scare your patients or your families. We'll see how that may be a misperception. Then we want to make it grounded and see how we can bring this to clinical practice and how do we move forward with that and where does that leave our current approaches. So as an outline, we have an ambitious agenda for today, and we'll try to get through all of these, but I'm happy to stop and take any questions at any point, or to table some of these if we end up spending more time in any of these areas. But our program focuses on several different areas, all converging around autism and developmental conditions. So research, clinical care, education, patient advocacy and policy, and media engagement. And I think a good place to start is to remind ourselves about the main areas of genetics. So we know that not all genetics are created equal. We hear the term genetics often laid out in the general media, but it's actually quite a few different things that I have divided into these four main areas. So we have things like pharmacogenetics, which studies how common genetic variants are going to affect our ability to metabolize medications, so meaning what the medications do to our bodies and what our bodies do to the medications. We also have epigenetics, which actually looks at the modifications that are going to affect our genetic material in regards to allowing it to express or repress some products of the genes. We have common genetics, which are the areas that the genetic variants that are going to determine general attributes like height and eye color and things like that. And then we have rare genetics, and I really want to underscore this because this is what we'll be spending most of our time on. So which are relevant for psychiatry and which are clinically relevant now and in the future. My argument is that the vast and the heaviest evidence is on rare genetics, specifically in the context that we'll look at, with a close second in pharmacogenetics. But we can spend more time talking about that, but that's not necessarily in its prime right now. So we mentioned rare genetics. What is that? We are going to be talking about genetic variants that we all have that are present in less than 1% of the population. That makes them rare. Now, these variants can come in two different classes. One is called copy number variant, which is just a fancy term of saying that there's a missing or an extra chunk of DNA somewhere in the entire genome. A missing chunk is called a deletion, an extra chunk is called a duplication. Now they have to be greater than 1,000 base pairs in size, so not super tiny, and they can be recurrent or non-recurrent. Recurrent means that different and related people may have the same missing or the same extra chunk of DNA because of the genomic architecture in that specific site. And non-recurrent means that it happens anywhere in the genome and it doesn't share the exact same breakpoints across different people. Then we'll also talk about single nucleotide variants, which are changes in a single base pair. So if copy number variants are extra or missing paragraphs in the book of our genome, then single nucleotide variants are changes in the letters that make up the words that go into those paragraphs. So much smaller scale. And then our focus will be on variants of large effect, meaning that if you have one of these genetic variants, it is very likely that you will express one of the clinical features that have been previously associated with it. Let me see if I can move my slide. Oh, there we go. So let's think about the autisms, and I purposefully put an S in there to reflect the heterogeneity that characterizes autism. And I think this is a good analogy to think about how someone gets to a diagnosis of autism. So let's think of this as an empty jar that we can fill up with balls of different colors. And once it is filled up to that autism threshold line, then someone will eventually get a diagnosis of being on the autism spectrum. So there are many different ways that we can fill out this jar. One is with genetic factors that are common variants, and these would be the bluish balls that you see right there. So you can see that there are some in that jar, but then we can add rare variants, which are the magenta balls. And this is what I mean by large effect. So common variants are much tinier than a rare variant that is going to fill up that jar much more quickly. And then we have environmental factors, which can be pushing people over that autism threshold to eventually get a diagnosis. And for different people, this jar could be filled up differently. So for some, it could be a single, very large rare variant. For some, it could be a host of environmental factors, or for some, it could be a host of common genetic variants, much smaller, but much greater in number. Now, moving towards our outline and thinking about research, how do we understand diagnosis through the lens of rare genetics? We have a couple of approaches that I'm hoping to share with you today. One of them is as a quick reminder of why we decided to work on autism. So we know that autism has a high genetic basis, and it's actually one of the psychiatric conditions with the highest genetic component. And this is evidenced by a high heritability. Now, heritable does not mean inherited, and I know that's a little bit of a nuance, but when we say heritability, it's just a way of saying that any given clinical condition has a strong genetic basis. Now, the other really interesting thing about autism is that we have individually rare but collectively common causes. So we were just thinking about rare genetics. They're present in no more than 1 to 2% of the population. But what we haven't discussed is that if you bring all of these rare genetic variants together, they can actually explain autism in up to 30% or 40% of cases. So another way of saying this is that if you've seen 3 people on the autism spectrum, you have very likely seen 1 person on the autism spectrum with an underlying genetic variant as the cause for their autism. Now, we also highlighted that there's a lot of heterogeneity and a lot of overlap, both in the clinical presentation of autism and in its genetic etiologies. And a way of understanding this that I finally got away with actually putting in one paper is thinking about this famous phrase from the Three Musketeers, all for one and one for all. So we'll delve more deeply into what that means. But just it's a reminder of how diverse the clinical and the genetic background in autism is. And then another key word that is going to help us throughout the presentation is pleiotropy. This means that individual rare genetic causes often affect multiple organ systems. So they could impact the brain, but they could also impact the kidneys or the heart. And that is going to be very key in our understanding of how we can get clinical traction from genetics in psychiatry. Now, this is another reminder of how we understand the universe, the genetic universe within autism. So we call this the autism umbrella, and everything that falls under the umbrella, again, is the universe of people on the autism spectrum. Now, we can see that there's several different colored bars that are making up that universe, but there's a lot of space that we either don't yet know how it is being made up or what's contributing to occupying that space, or we have just not listed it here. Now, that's one axis of thinking about autism. The other axis is about thinking specifically about these genetic conditions. So we have things like Down syndrome, for example, on the left. And what this means is that if you see, there's only a proportion of this bar that falls under the autism umbrella. So most people with Down syndrome are going to be outside of the autism umbrella, and a few are going to be in there. Now, the opposite is true, let's say, for Fragile X syndrome. So most people with Fragile X are going to be within the autism, under the autism umbrella, meaning that they have a diagnosis of autism, but then some are not going to have that. So the other key point to highlight from this slide is that a genetic and clinical diagnosis can and often do coexist. So it's not like if you have Down syndrome, then you are no longer eligible to have a diagnosis of autism. Autism is a clinical descriptive diagnosis, and genetics just starts from a different axis, and they can often converge at the same point. So now let's think about why it is relevant to think about genomic psychiatry. And I see that someone wants the umbrella. Happy to facilitate that. So there is a significant public health impact about thinking of autism and genomics. So I updated these slides to reflect our new home here in Canada and in Edmonton. So we know that Canada's population is just shy of 40 million. Now, Edmonton's population is a little over 1 million, and I'm using very conservative estimates here. So the frequency of autism in the general population is about 1 in 50. And again, this is a conservative estimate. Recent numbers from both the CDC in the US and from our Canadian partners actually put it at 1 out of 36 in the US and 1 out of 37 people here in Canada. But for the sake of being extra conservative, I'm using the 1 in 50 figure. Now, we just learned that there is up to 40% in up to 40% of people, we can identify a genetic cause, meaning a pathogenic copy number variant or single nucleotide variant. So even if we use those conservative estimates, there are over 158,000 people in Canada with autism stemming from a genetic cause, and over 4,400 in Edmonton alone. And this number is likely going to be much higher. Like I just did these calculations and cut them in half to give us a lot of wiggle room for being conservative. But just think about these numbers. And we were talking about rare genetics and how less than 1%, and this is a very low frequency genetic change, but this is what happens when you bring those genetic changes together. This also means that there's more than twice people with autism because of a genetic cause in Canada, as there are people with HIV in Canada. And I'm just providing this as an anchor so we get to think about resources that thankfully are appropriately allocated for HIV clinical care, research, and public health. And then let's think about an equally large, or actually twice as large a population that right now is an invisible minority. So how can we address this challenge and guarantee equitable access to treatment and the best use of this information for those families? We can go back to our Three Musketeers story. So if we start by all for one, we can then try to understand how many genetic causes can contribute to the same diagnosis, as is the case for copy number variants in autism. So this is one study that we carried out a little while ago, and it's only one of many really amazing studies that have come out after this one. But we were using the power of very large clinical studies, meaning studies where people are referred for genetic testing that have very limited clinical information, maybe just a referring diagnosis, but very large numbers, thousands of people. And then combining that with the power of very detailed autism studies, where we have a lot of really thorough clinical information, but where maybe the sample sizes were not large enough to study the contribution of these very rare genetic events. Now, I'm happy to report that since this study, those autism studies have grown exponentially in size, and we are now in the space where we're able to get really nuanced clinical data and genetic data. But at that time, we were using this two-tiered approach to infer whether or not a specific rare genetic change was contributing to risk. And we did find several cases who had a recurrent copy number variant, meaning a missing or extra chunk of DNA that would have been deemed pathogenic in clinical cohorts that was leading to autism. Another way of saying this a little bit more straightforwardly is that these are people on the spectrum that were potentially buried in the supplementary methods of some of these papers, because those autism papers did not have the strength to say, hey, this is a risk factor, a genetic variant that is increasing the chances of someone developing autism. And with this two-tiered approach, we were able to pull out that data and to infer that pathogenicity using data from very large clinical cohorts. Now we know that de novo and familial genetic changes were relevant, and only half of the clinically relevant CNVs were known to be de novo. Now this is a really key point. We haven't talked too much about what de novo means, and it just means that a given genetic change is not present in the biological parents, meaning that it happens spontaneously on the kiddo or on the person that we are looking at. And for the longest time, we were focused on looking only at de novo changes, meaning both parents don't have autism, they have a kiddo with autism, and that kiddo with autism also has a genetic variant that the parents don't have. So it makes that analysis more straightforward. But then we were able to see that sometimes the parents do have that genetic change, and they may or may not express some of those clinical symptoms. Now with this study, we were able to finalize some associations between deletions, and duplications in these different genomic coordinates and autism, and we were able to increase the diagnostic yield for this type of variation in autism. So again, all for one, a good example of how we can look at all or very many genetic causes for one clinical diagnosis, which is autism. Now we can do the opposite. We can think of one for all. We can look at many diagnoses due to the same genetic cause. So instead of starting with autism, then we can start with genetics. And then we get together a group of people with the same genetic variant, and we can see what clinical features they have and how to best understand their presentation. And this is what we did a little while ago, and this has been an ongoing thread of our group that I'm happy to report that we're bringing here to the University of Alberta to expand on this work. So we identified that a missing chunk of DNA on chromosome 17, a recurrent CMV in 17q12, was increasing the chances for autism and schizophrenia. And this was previously unknown, and I'll tell you how we did it. But first, let me orient you to how to understand one of these genomic graphs for those of you who are not necessarily familiar with how to read one of these graphs. So we can see here at the top, this is called an ideogram, and it's just showing us the entire chromosome 17. Now it has a little arm and a big arm. The little arm is P for petit in French, and the big arm is Q just because Q comes after P, so less creative on that end. And then all of these different colored bands are the specific regions of that chromosome. So this ideogram is telling us that it's chromosome 17. We are looking at the band Q, so the big one, and then at the address 1, 2. Now, if you want to impress your geneticist friends, this is always single digits. So we have band 1, subband 2. There's nothing like 17q12 or 15q13. Like those are always expressed as single digit numbers. So then we know that this is where our genetic variant of interest is happening. And then we will just do a zoomed in version of this. So this gray area is this little part of the chromosome. And then here we see what genes are included in that genetic region. So we see all of these guys over here in the middle are the genes that are lost on people who are missing this part of chromosome 17. And then this part here in the light blue are the recurrent features of the genome that make this variant happen over and over again in the same spot for unrelated individuals. So we can see here that this person, this is the result of a typical genetic test called chromosomal microarray. We can see that everything that hovers around the 0 line means that you have 2 copies of that genetic material, which is normal. And then we see here that this person has 1 copy only of the part of chromosome 17 that we were thinking about. Now, these are the pictures of the kiddos and the adults who participated in our study. And I really like this image because it brings to light why we are doing the research that we are doing. And it's really lovely to remember that we're not talking about numbers, but we're talking about people and people's lives. And you'll see that throughout not only the presentation today, but the philosophy of our group is that we want to make sure that we give back to the community that so graciously helps us understand the genetic basis of autism and other psychiatric conditions. So one of the things that I wanted to highlight here is that although everyone in this image is unrelated, each column is one same person across time. So we get to see how clinical features change. And the other thing that we get to see is that even though they're unrelated, if you look at them at similar ages, you can see that they could be cousins. Like there are some similarities, including maybe a little bit of a lower nasal bridge, a little bit of a bigger forehead, that are very likely due to the fact that they all share this same genetic variant in chromosome 17q12. Now we started getting some referrals when I was back at Emory for genetic testing for people on the autism spectrum. And we started identifying that many of them, like a handful of them, had this 17q12 deletion, which was unusual because this was not described before. And this slide highlights the power of collaboration. So then we were able to work with our clinical partners and find out that there were 18 additional cases out of 15,000 people that had been referred for genetic testing at the time. And then we looked at control populations, meaning that they did not have an indication for genetic testing. And we did not see a single case of this 17q12 deletion in that control population. And then we grew these collaborations and we grew our partnerships with other academic and clinical institutions. And we looked at the frequency of these deletions in both large cohorts of people on the autism spectrum, of people with schizophrenia, and combined together. And we were able to see that we had 24 deletions out of 23,000 cases and 0 out of 52,000 controls, meaning that this was a very significant risk factor for you being in one of these teams. And this stood after correction for multiple testing and different ethnic origins. So then what we learned from this one for all Three Musketeers story is that 17q12 deletions have a high chance, give people a high chance for developing autism and schizophrenia. This deletion is rarely seen in controls. The majority of cases are de novo, meaning that it happens, as we were reviewing, spontaneously on those kiddos at first. And when it is inherited, the parent usually has a related diagnosis like bipolar disorder. So that talks about variable expressivity, meaning that, as we said before, because genes haven't read the DSM, they don't know that they're supposed to go one route and only increase the chances of someone developing autism versus schizophrenia versus some other medical conditions, which is the case for 17q12 deletions. So people with these deletions not only have potentially autism or schizophrenia, but they may also have kidney problems or magnesium homeostasis problems or reproductive tract problems. So again, we can see this concept of pleiotropy, meaning that the same genetic variant can have effects over many different organ systems. And then we know that this contributes to that shared genetic pathway idea, even within supposedly different neurodevelopmental or psychiatric conditions. So again, because genes haven't read the DSM, then that line that we draw arbitrarily between schizophrenia and autism, for example, even though clinically it is very meaningful, biologically it may not be the case. There's a lot of shared genetic susceptibilities. Now we are taking this to the next step to try to understand a little bit better how these deletions lead to these medical and mental health co-occurring conditions. And we're really excited to go beyond dichotomous and categorical diagnosis, meaning autism, yes, no, in this population, to actually understand continuous and quantitative traits, which is a much more nuanced and rich understanding of those clinical features. So it's sort of us going from autism, yes, no, to actually looking at social functioning on people who have these genetic variants and see what's making them fall on one area of that normal distribution curve versus another. And we have been focusing on remote and longitudinal data acquisition because this is a rare genetic condition. It means that we need to partner with several collaborators across the globe, especially with several family groups. And that means that we have to adjust our assessments because it's often not possible to bring everyone together for a study unless you do that remotely. And this has been kind of very fruitful in the very significant challenges posed by the COVID pandemic, because we were already set up to do that remote data acquisition. And we also want to understand those clinical phenotypes. So again, going from diabetes, yes, no, or kidney problems, yes, no, to let's see where the blood sugars have been over the past several years, or let's look at kidney function over time. So to get much more granular and nuanced data. And then we also want to understand how background common genetic variation is going to fill that jar. So let's think about that jar at the beginning. 17q12 deletions are one of those big magenta balls that is going to fill that jar quite significantly. But we know that not everyone with that deletion is going to develop those clinical features. So what other common, smaller blue balls or environmental factors are going to be pushing someone over the edge in the presence of this rare genetic variant? And this is another way of conceptualizing what we were talking about, going from categorical, dichotomous yes-no diagnosis to quantitative diagnosis that look at very specific domains and how they vary not only over time, but across different populations. So this is a paper we published a little while ago, exemplifying that concept. And I think it's really interesting. And what I want to bring to our attention is this idea of a shift. So indulge me for a little bit. Let's say that we're talking here about, it could be social difficulties or social abilities. So these are normally distributed in the general population. And then you have a population of people with a rare variant that increases the chances of you developing some social challenges or of having a diagnosis of being on the autism spectrum. So we know that having that variant shifts where you are on that normal distribution to here. But it is a relative shift. It's kind of a misnomer. Shift implies that it is relative, but it is not that it is going to absolutely make you deterministically fall on the space where you will be diagnosed with an autism spectrum disorder, but just that it is going to increase your chances of being there. So let's say if someone starts here in regards to their social abilities, the higher they are, the more likely they are to have some social difficulties. If you start here, then that can bring you over here. But if we go down, then we see that a lot of people in the general population fall on that space in the normal distribution curve. But if you start here, then that same shift is actually going to push you all the way into this space where you will most likely have a diagnosis of the autism spectrum. So it's another way of thinking about how genetics can inform our diagnosis and thinking about susceptibility and, again, protective genetic factors. Now, bringing all of this together, the all for one and one for all idea, we've been working with several colleagues precisely to recapitulate all of these stories. We spent a lot of time talking about 17q12 deletions and about the other rare genetic conditions within autism. But this is only one of the examples, and there's actually tens, if not hundreds, of different individually rare genetic conditions that are going to increase someone's chances of developing autism or other mental health clinical features, as well as other somatic or medical phenotypes. So things like microcephaly or smaller head size or heart problems. And this is just a way of highlighting that this pleiotropy or this heterogeneity or ability of gene variants to confer effects over multiple areas is more the norm rather than the exception. Now, I know that was a little bit of a whirlwind, so I want to take maybe a little pause and see if anyone has any questions up to now or anything that you guys wanted to review a little bit more before we shift gears. I'll keep an eye out on the chat. But if not, then we can go into an entirely different area of our group. So we know, because of all of the things that we said, that genetics are really important for autism. And because of that, genetic testing is the first line recommendation from multiple professional societies for people on the autism spectrum after a diagnosis is made. And this is a big highlight. Genetic testing will not diagnose autism ever, just because it's not that it can, but it's just a different concept and it's a different starting point. So the question is not even relevant. What genetic testing can do is explain why someone may have autism in the background of having one of these genetic variants. I think we have a question in the Q&A asking about whether we can differentiate the phenotype of autism based on Fragile X or other genetic variants. Yes, that's really interesting. And that's one of our main aims. And we'll get to see a little bit more about this. What we want to eventually accomplish, and that work from our team and others is now poised to do, is to do exactly what that question is asking about. So we want to understand a behavioral blueprint that is coming, a behavioral and medical blueprint that is coming from these rare genetic causes of autism, like Fragile X changes. So we know, for example, specifically about Fragile X syndrome, that anxiety tends to be a big component of those clinical features in addition to autism. So I don't know if flavor is the right word, but it's the one that comes to mind. The specific nature of autism in Fragile X can be a little bit different than the specific way that autism manifests in someone with a different genetic variant, including not only as it pertains to the diagnosis of autism, but also as it pertains to some of the other medical and psychiatric conditions that often happen simultaneously with autism, anxiety being one of them. So yes, that is the goal, and there's some really interesting work being done to push that forward. So after answering that question, we get back to genetic testing. We know that it's the first line recommendation from multiple professional societies, including our own Canadian Pediatric Society, the American Academy of Child and Adolescent Psychiatry, American Academy of Pediatrics, American Society of Human Genetics, and the International Society of Human Genetics, meaning there's a ton of people who are recommending offering genetic testing for autism as a first-line tier. Why are they recommending that, and why should we do it? We know that it can provide an etiological explanation, meaning that it ends a diagnostic odyssey for many families face. We know that it gives us better recurrence estimates, and it can be helpful for family planning to empower families to make the decision that best aligns with their values. It can help connect with other families who have the same genetic variant, and I cannot understate the importance of this. So for many of these families who felt that they were the only ones in the world and that they didn't have a support network that they could rely on, all of a sudden they now have the key to a secret door that they didn't even know existed, where they can meet a lot of other families with similar challenges and similar strengths. And just going to one of these Facebook groups and learning that there's an adult who's 35 who has the same rare genetic cause for their autism as the kiddo in that family is a big deal for those families. Like, many of these families don't even know if their kids or if the adults are going to make it to middle age. So having that information is extremely helpful, even if it sounds simple. And then this genetic information can also alert us about potential medical co-occurring conditions. We heard about that with 17q12, and it is not exclusive to 17q12, but many of these genetic variants also increase the chances of someone developing cardiac conditions or other medical or somatic conditions that are going to be relevant for treatment. Now, the recommended testing, I'm going to say, used to be chromosomal microarray and Fragile X, but there is emerging evidence shifting towards thinking about exome sequencing as a first-year test for autism and neurodevelopmental conditions. So again, science is evolving rapidly, and microarray is going to detect extra or missing chunks of DNA. Fragile X needs a special test, and it is going to look only at the Fragile X gene for the very specific trinucleotide repeat expansions that cause Fragile X. But exome sequencing actually can look for extra or missing chunks of DNA and also read all of the words looking for those single nucleotide variants, so for those letter changes that we discussed at the beginning. So much higher yield and a similar or lower cost. And I would say actually it's becoming dramatically lower cost, which is pushing the field towards adopting this test as the first-year test. How are we doing? We just learned that it is our professional duty to offer genetic testing to all families. And I also underscore offer and not do genetic testing. It's on the families to make the decision for themselves after they are presented with this information. So we looked at this in our Rhode Island Consortium for Autism Research and Treatment study, where we had over 1,800 participants from Rhode Island, which is where I was coming from, and which is also the smallest state in the US. And this is going to be relevant because we can ask some unique questions that will be challenging to ask in much larger spaces. So we know that the target of recommended genetic testing discussions and the offering should be 100%. How are we doing? We published those results a little while ago, but let me break those down for you. On the left, we have a graph that's showing us the age of enrollment on the x-axis, x-axis in years. That's why it threw me off a little bit. And then on the y-axis, we have the participants with any of these genetic tests. So we see that the yellow-orange balls are karyotype, the older genetic test. Then we have CMA, or chromosomal microarray, which is the test we were talking about, in blue. And in dark blue, we have Fragile X. So we see how that evolves depending on the age at which participants enrolled in our study. So if they're really young, they have a lower chance of having had a karyotype and a higher chance of having a microarray and Fragile X testing. And the opposite is true if they enrolled once they were adults. So much lower chances of having had a microarray, a little bit higher of having had a karyotype, and a bit higher of having had Fragile X testing. Now on the other graph, we have very similar data, but instead of looking at age at enrollment for the participants, we are looking at the calendar year of the time of ASD diagnosis. Of course, because some of these genetic tests came out after the participants were born or may have enrolled. So we can see that, of course, in 1995 to 1999, CMA was not even widely available. And as it started becoming more available, the percentage of participants reported having had this test increased, while those that had karyotype decreased. And that's normal, and that's what we expect, because CMA replaced karyotype for the majority of indications. And Fragile X decreased a little bit as karyotype increased. Now, what I want to bring to light is that let's look at the y-axis. Those numbers are tiny. So even in the best case scenario for the most recently diagnosed kiddos, microarray was only happening in about 10% of the cases. So again, there's a big gap that we still have to fill. We have a question on the Q&A about a family member, a son who was adopted and has mild ASD. So where can you access genetic testing for him? I'm happy to report that that is one of our biggest pushes with the relocation of our group here to the University of Alberta. So we will be developing new clinical services, among them a genetic counseling service that I'll talk more about, that will be focused specifically on having these discussions and carrying out genetic testing for families who agree with this. In addition, the medical genetics team here, led by Dr. Kanu and his colleagues, also offers genetic testing. So there are going to be several avenues where we can make this happen. And I know that you haven't asked this just yet, but I'm happy to report that genetic testing is covered by Alberta Health Services, thankfully and gratefully, because it is a standard of care recommendation. Okay. So going back to how we're doing, unfortunately, not too great. So we know that we wanted to have those discussions in about 100% of the cases, and they were only happening in 3% of the cases. So there's a dramatic gap to fill between medical professional recommendations and actual clinical practice, which leads us to focus on a large-scale effort for the implementation and dissemination of these recommendations in the clinic. So why is this not happening, and how can we do better? What we did at this point was ask the families. That's always been our priority, and that's the first thing that we wanted to check in. And this is some unpublished data, but we developed a survey assessing the attitudes, perceptions, and results of genetic testing in autism for the same Reichard population that I was alluding to a little bit earlier. Now, everyone had either a community diagnosis of autism or a positive ADOS, which is the gold standard for autism diagnosis. Now, the preliminary results is that we had a pretty healthy number of responses for the complexity of the survey, and there was very high interest in genetic testing from the families of autism kiddos on the spectrum or the autistic adults themselves. They had familiarity with some basic genetic concepts, but not so much with the specific terms. The majority of the families reported not having been offered genetic testing, and they accepted genetic testing when offered in 91% of the cases. So families are telling us that they want this and that the conversations are not happening. And the yield, meaning the chances of finding a genetic variant that explains autism in that population, was 27%, so very close to that 1 out of 3 number that we were citing. Now, this is a slide that highlights some of the richness that we get from that qualitative data. And again, one of the things that continues to make us move forward, we made sure to develop this survey in Spanish as well. That's my native language, and we had a pretty significant Spanish-speaking population back in Rhode Island. And I think it's both endearing and motivating to see that one of the questions we asked the families was whether any of the questions in the survey upset them. And then this family is telling us that yes, because she couldn't really say the words that were within that space. So highlighting that thirst for knowledge. But then when we ask about any additional comments, they just want us to keep helping the kiddos on the autism spectrum. So there's this interest from families to actually overcome these barriers to knowledge in regards to genetics. Now, moving on to clinical care, we already covered a lot in the research space, and I'm happy to report that we are developing a comprehensive strategy that also includes clinical care as a crucial way of helping this population. So how can these rare genetic variants of allergic effect inform care? My argument is that that is possible now with readily available resources by modifying the treatment algorithms to include clinically actionable interventions. There's a lot of fancy things out there, like clinical trials for gene therapy or these other compounds that are called antisense oligonucleotides that look promising and that are cutting edge but not widely available. But there are things that we can do right now. And I see that there's a question from one of our pediatricians in the audience, and timely access to geneticists and genetic counseling is you're spot on. It's a very similar theme that happened in Brown and in Providence, where we were coming from. And that is one of the things that we want to tackle. So I would be delighted to have more of those conversations and see how we can decrease the barriers to access. So thank you for that question. Now, how do we move towards that actionable genome? We use our phenotype first and our genotype first approaches, so the all for one and one for all ideas that we talked about. And then we identify decision points where that genetic information could alter management. And I label this the actionable genome. And it could be susceptibility to specific medication side effects or pharmacological treatment based on the underlying biology, prophylaxis of co-occurring conditions, or many others. So I just want to give you an example of how one of these rare genetic variants can inform our treatment. Now we have these two people with a deletion in their chromosome 15 q13.3, different from the one that we talked about. Now, the first case is a 39-year-old male with psychosis, significant rage outbursts, and epilepsy, and in treatment with a whole host of psychiatric medications and frequent hospitalizations, mostly for aggression. Now, the second kiddo is a 17-year-old male with autism and behavioral outbursts, on treatment, again, with a lot of different medications. Now, we did genetic testing and we identified this deletion. So we know that that deletion increases the chances for schizophrenia and autism, and also for epilepsy, and unfortunately for aggressive behavioral outbursts. Now, the interesting thing is that that region that is missing in chromosome 15 in these two cases includes the cholinergic alpha-7 receptor. So this is a nicotinic acetylcholine receptor. And lo and behold, we have a lot of interventions that work on the nicotinic system. So this is just to show you a similar graph like the one we saw. This is chromosome 15, and this is the region we're talking about. And this is the one that is missing in our two cases. On a side note, this is the region that is missing in Prader-Willi and Angelman syndromes, but this one is a different one in chromosome 15. Let's see. So with that information, we were thinking that if we could just modulate that nicotinic cholinergic receptor function, biologically, it made sense. It is a little too simplistic, but it made sense, and we had good tools and good preliminary evidence to know that this modulation was tolerable and safe in kids, and that it had been tried in an adult with a 15q13.3 deletion before. So galantamine stops acetylcholine from being broken down, and it may have a little bit of allosteric positive modulation on that receptor. So we were thinking, again, very simplistically, you have one less copy of that receptor. Let's try to boost that cholinergic tone and see if we can help you. And our preliminary evidence is showing us that it does help. So for case one, they went 10 months without hospitalizations. And for case two, we were able to greatly reduce polypharmacy. And this is an example of one of our cases where we started the galantamine, and we can see here the date, and then we can see the frequency of aggressive behavioral outbursts in the inpatient unit. And the dashed red line is when we started galantamine. So those episodes decreased quite a bit. Again, this is not a clinical trial. This is a case series. where we are gathering some preliminary evidence to support looking at this in a much more detailed way to develop the evidence for these recommendations. But it is looking very promising. So we have expanded the recruitment for this case series, and we have come across several other people who have been treated with galantamine in this setting, or who we have treated in our system with galantamine. And we are working on publishing this case series that can serve, as we said, as preliminary data for the clinical trial proposal. Now, we love working with the families, and we'll saving the best for last. And we want to make sure that we deliver back to the families what they so kindly put towards research. So we are developing a lot of materials for learning for the families and for the lay audience. One of them is an interview with a lovely, lovely family member who herself has also that 15q13.3 deletion. Of course, all of these, we have consents, and these are study participants, and that's why I'm able to share this with you. But we get to see the story behind the data, and then we develop some learning materials for those families as well that we can share widely. So precision medicine in psychiatry is relevant now. We know that many psychiatric conditions have a strong genetic basis that should be uncovered clinically. That genetic testing is the standard of care for autism and some other psychiatric conditions that will, and that list will continue to expand. And that genetic results may lead to actionable clinical interventions with currently available pharmacological and behavioral therapies. So we are implementing all of these clinical services, and I'm happy to report that after the success we had in doing this at Brown University and Bradley Hospital, we are developing those services here. And I like to always think of a sort of silly comparison that gets the point across really well, which is, can precision medicine really work? And my argument is that we do have a pretty good example that it does work. So I mean, I wear glasses, and I think many of us in the audience may wear glasses as well. And this is how I like to think about precision medicine. So if we said that everyone who's nearsighted needs glasses, and we just have one type of glasses with the same lenses for everyone, no one is going to see anything, even if they share a diagnosis. But once you're able to bear into account the specific characteristics of that person's vision, then you can fine-tune their prescription for lenses. And even if they all share the same diagnosis of nearsightedness, they are going to have an individualized treatment that will allow them to be the best version of themselves that they can be, in this case, have really good vision. And I think this is very similar to autism. We cannot expect that a diagnosis of autism or a neurodevelopmental disorder is going to allow us to just have the same one-size-fits-all treatment strategy for those who need treatment, because there's a lot of uniqueness and a lot of strengths and challenges that are going to be different across different people. So let's think of that when we think about precision medicine. I want to be mindful of the time, and I only have a couple of minutes left, and I want to make sure that we have ample time for questions if we have any. So I will just skim through some of these remaining slides. This is just to tell you that we are developing the clinical services here in both genomic psychiatry and genetic counseling, to both talk about genetic testing and carry that out, and then to use that genetic information to tailor psychiatric treatment for those who need it. We are developing an algorithm and how that would work, and have been working with our partners at AHS and Casa Mental Health and the L&D Clinic to put this in place. And we are very driven towards education. So I won't get a chance to go in too much depth about this, but one of the best ways to implement and to tackle this gap is by developing strong educational programs in genetics to psychiatry training worldwide, and enhancing and giving tools to our workforce to use data that we're learning from this. So as part of the International Society of Psychiatric Genetics, I co-lead the Education Task Force, and we identified what every psychiatrist should know about genetics. And then with the National Neuroscience Curriculum Initiative, led by Dave Ross and team, we have been developing some of the modules that are going to be covering what those recommendations allude to. So I have the pleasure of working on the autism spectrum disorder module, but this is a much bigger effort, again, spearheaded by our new chair, Dr. David Ross. We were able to develop a subspecialty training in autism and neurodevelopmental conditions at Brown, which is an initiative that we also want to carry out here at the University of Alberta, and for which we've received significant support. So I'm excited about bringing this to the table. And then, most importantly, and the part that I want to end with, is how we bring everything together by giving back to the families who participate in these research studies. So I find that it is a moral and professional obligation of our group to tell the families about the discoveries that we're making on the research side, and to make sure that there's a direct line, not only to learn about what the findings that are coming from the studies that they very kindly participated in, but also to hear directly about their priorities. And we do this, and it's a big focus of our group. So we organized international conferences for families with the same genetic conditions, in this case, 17q12C and Vs. And we can see all of them here in Rhode Island a little while ago at the 17q12 family conference. And we have been collaborating with artists through photography and video and several other exhibits, which is just such a pleasure to bring to highlight the unique stories of people and families on the autism spectrum. So this initiative, we already hit the ground running here in Alberta as well. And I'm happy to report that the next chapter of these initiatives will be happening over the summer here as well. So tune in for what's coming from that space. We also put together a lot of resources for the families, including newsletters to serve as a communication strategy with them. And we did a really fun video. I'm biased, but I would like to think that it's a fun video explaining all of these things. We noticed that knowledge was a big source of that gap. So we did an animated video tailored towards the general audience about autism, genetics, and genetic testing that is freely available in YouTube and in our website in English and in Spanish. We're translating that into French and want to expand into other languages as well. So I don't have the time to show you the video, but I encourage you to check that out if you're interested. So the future directions is that we want to continue integrating all of these main areas into a very cohesive program, and to leverage tools from other fields like implementation and dissemination science to start getting some traction towards precision medicine. And ideally to start working on developing treatments for those who need them based on readily available strategies that can be pretty inexpensive and that have been, for example, repurposing of medications or things of the sort that I think can go a long way. And that would be readily, readily available to help the families who need that. So I would like to end by thanking everyone. This is not at all something that any one person could do by themselves. And I am privileged to have an amazing team at several different spots. And most importantly, the families and the participants. So thank you very much for your time, and I can remain around for a little bit if you have any more questions.
Sure, Dr. Moreno De Luca, it looks like one of the attendees wants the link for the YouTube video. So maybe if you can put that up, we'll talk about the evaluation process and accreditation, and give people a bit more time to put in their questions for your very fascinating and clinically rich and relevant presentation. I feel like I need to go to like your genetic seminars. So, okay, so while waiting for more questions to pop up, just a reminder for people that these rounds are accredited by the Royal College of Physicians and Surgeons of Canada, and also the College of Family Physicians of Canada for live attendance. And for the Royal College, these rounds are approved under section 1 as group learning for up to 1.25 hours. And then for the College of Family Physicians, these rounds are 1 credit per hour group learning program that has been certified for up to 1.25 main pro credits. We also appreciate your feedback. Our Grand Rounds Committee does look at all of the feedback that has been submitted. And so you can either go to the link or the QR code to submit your evaluation, which we would much appreciate. So we do actually have one question that came in. Oh yeah, Dr. Van Riper. Yeah, we'll both join your seminars. So she is asking, are you planning any case consultation service for discussion of cases where a genetic struggle has been identified to consider what targeted psychopharmacology could be considered, like the example cases provided?
Absolutely. Thank you very much for that question, Dr. Van Ripen. It's almost as if I had planted that seed in there and looked for that specific question, but you're describing our genomic psychiatry consult service that we are hoping to launch very soon, which aims to do exactly that. So just to underscore some of the nuances there, this will not be about pharmacogenetic testing. As we remember at the beginning of the talk, pharmacogenetic testing looks at common variants that we all have that are going to impact how we metabolize medications and what medications do to our bodies. That's a different set, and that's not what we were talking about. But we will be covering how we can think about psychopharmacology in light of a genetic background. So let's say, for example, someone has autism because of a 22q11 deletion, and then we know that they're also more susceptible to cardiac problems. And then if you're thinking about starting an antipsychotic for very severe resistant behavioral outbursts, then you better know that you want to know that there's not an underlying yet to be discovered cardiac anomaly that you could make worse by lengthening the QT, for example, by using some antipsychotics or things like that nature. It's exactly the type of recommendations that we want to put forward in this service. And they don't all have to be regarding psychopharmacology. For example, we know that, let's say, some people with 22q13.3 deletions, which include a gene called SHAM3, are going to have a much more marked challenge with their expressive language, challenges. So by having access to that information, then maybe instead of spending a lot of time and resources in speech therapy, we can move more quickly towards assistive communication devices and get a much better bang for our buck and help those kiddos communicate much better with their families. So again, thinking about genetics to give a kiddo an iPad, kind of a simplistic way, but also an accurate way of emphasizing that it's not all about either medications or super fancy interventions that are not readily available. There's a lot of stuff that we can do now.
So we have another question. Thank you for answering the previous one. The next question from Dr. Janica, our pediatrician from before, is there a good correlation between pharmacogenetics and genetic testing in kids with autism with positive genetic findings?
Not really, and I think this is a great question because it emphasizes again the difference between common and rare genetics. And I think I'm a little bit of I have some skepticism about pharmacogenetic testing, and I'm a big genetics fan, but I just think that we still need a little bit more evidence to recommend this widely, and we need to see how big of a difference it makes. Like there are some clear-cut examples, let's say, of people of Asian ancestry who are going to be placed on carbamazepine because pharmacogenetic testing can actually let you know who is much more likely to develop Stevens-Johnson syndrome, which you want to avoid at all costs. So that's a clear-cut indication that is very different from what we were discussing today. But the examples in that space only apply to a select number of people. And I'm a little bit concerned in regards to the way that results from pharmacogenetic testing are presented. Like, you don't necessarily know what's happening behind the scenes and how they compile those algorithms. And then you may get a report that looks very much like a stoplight with red, orange, and green. And when we see something in the red, we think about, well, maybe I should stay away from that. Well, what it could be saying, if the evidence was there and we could replicate the algorithm, is that maybe someone is a slower metabolizer. So they may need a lower dose rather than for us to stay completely away from that medication. And we already don't have enough of an arsenal to help our patients with, that I don't want to take things off the table so quickly, especially if we don't have the evidence to know that they should be off the table. So again, I'm a little bit more skeptical about the immediate role of pharmacogenetic testing, although I really want to see the evidence develop, because I think it would be fantastic. Like, think about people on lithium, let's say adults on lithium, or clozapine. Like, if you knew who was going to develop those side effects, that would be big, because some of these medications are very helpful, but are much less used because of the potential for these side effects. Now, the relation between pharmacogenetic testing and rare and positive genetic testing, it's going to be there in the sense that we all have common variants that are going to determine our height and our response to medications. And some people have rare genetic variants that also increases the risk for things like autism. So they are coexisting, but it's not, it's more of a potential additive relationship than exponential, where if we have a kid with Rett syndrome, a rare genetic condition, then we better make sure that we do pharmacogenetic testing. That's not really the case. So it's not synergistic in that way. And I'm happy to expand more if helpful, but that's kind of how I would think about that question. And also, I'm happy to report that we will soon be sharing the link to the YouTube video, which you can also find in our website. And in YouTube, you just type precision medicine genetic autism, and it comes up in both languages.
Yeah, so just to let you know, Andrea, I don't see the link in the Q&A. It's still in the webinar chat. Oh, actually, I guess people can see the webinar chat, so that should be okay. All right. So our anonymous attendee has another question. We test most of children with ASD for Fragile X and the chromosomal microarray. Very few are actually identified with a genetic variant. So I guess the query is, what should be the next step? For example, should we send all of the ASD patients to genetics for, I guess, whole exome sequencing?
Great question. And you are right that the yield of CMA and Fragile X combined by themselves is going to be closer to 20% rather than the 30 to 40%. So the yield is going to be a little bit lower. It can be much higher if you factor in several other psychiatric or medical co-occurring conditions like intellectual disability or seizures or congenital anomalies. But it could be lower if you think of someone that is only presenting with autism and does not have any of these other co-occurring conditions, especially intellectual disability. But the recommendations are that we offer genetic testing, and these are moving towards whole exome sequencing right now. So this is something that we really want to move forward and build on the amazing strengths that are already here in Alberta, because as I understand it, and I'm still getting more acquainted with the system here, as you mentioned, we can do Fragile X and CMA, but exome sequencing requires a special additional level of stringency that usually involves the Genomics Resource Center in Calgary with special approval and the presence of either a medical geneticist or a genetic counselor. So we are having all of those conversations to see how we can extend and enhance the work that our colleagues in medical genetics are doing, including with our own genetic counselor who's on our team and many others. And in bottom line, so detaching the logistics from what should be happening, in my view, yes, absolutely. Everyone who has a diagnosis of autism should be having exome sequencing at the minimum. Now, how do you put that in place? There's going to be a lot of nuances depending on where you are enacting this. But I think the goal and the recommendations are the same, is that the implementation of the recommendations, of course, need to be grounded on the local environment and ecosystem.
Thank you so much. So we're, finishing up here, and I think we did answer, all the questions. And these are just really exciting, I think, directions for, Edmonton. I think the province, actually, even with you being with us and really spearheading these efforts to, bring, this genetic assessment and also counseling to benefit our, families. And I guess I can put in a plug because it sounds like you're also scheduled for our Psychiatry Research Day, right? And
Yes.
what do you remember what date is that?
I think it's June 7, if I'm remembering that correctly.
June 7th. Okay, all right, because keep an eye for that because you're a keynote speaker there. And I guess anybody in this audience who also wants to hear more from Dr. Moreno De Luca, then that's Dr. Van Riper confirming June 7th. But anyways, you can check with the Department of Psychiatry for more information about that research day. So yeah, thank you all for participating. And we'll end it at that and continue our discussions in other forums.
Thank you so much for having me. It's been a total pleasure.